Welcome to this update on molecular dermatopathology. So the objectives of this talk are to update you on some recent improvements in understanding of disease pathogenesis in dermatopathology and how that leads to some powerful new tests, help you understand the tests, their application to diagnosis, and also the potential to identify treatment targets for targeted therapy, and then show you over time the consequences for disease classification. So I want to focus on some particularly troublesome areas in dermatopathology: dedifferentiated melanoma, melanoma with spitzoid features, desmoplastic melanoma, digital papillary adenocarcinoma, hydroadenoma, papillary eccrine adenoma, porocarcinoma, nodular fasciitis, ertine chest disease, aggressive epidermotropic CD8 positive T-cell lymphoma, and subcutaneous panniculitis like T-cell lymphoma. So starting with dedifferentiated melanoma, this is a patient that we encountered with a conventional melanoma in the top left panel, but who later developed a spindle cell neoplasm which was diagnosed as an undifferentiated sarcoma. And we wondered, could this be really a dedifferentiated melanoma which had lost immunostain markers? So this is SOX10 and this is melanA. So we wondered if the BRAF or NRAS driver which initiated this primary melanoma was still present in this tumor, and it turned out that the primary melanoma plus this tumor had the same BRAF V600E mutation, and because BRAF mutations are exceedingly rare in sarcomas, we concluded that this tumor likely represented a metastasis of this tumor and therefore represented a dedifferentiated melanoma. So this relies on a couple of features of melanoma and sarcoma. One is that BRAF and NRAS mutations are exceedingly rare in sarcoma, and the other is that the initiating BRAF mutation is essential for the survival of the neoplasm, and therefore it's retained even late in tumor evolution when the tumor becomes dedifferentiated and loses its melanocytic markers. So here's another example of similar application of BRAF and NRAS sequencing. So this is a huge undifferentiated tumor on the knee. This is what the histology looked like. Immunostains were negative for everything, but on sequencing this turned out to have BRAF V600E, identifying it as likely an undifferentiated primary melanoma and also enabling targeted therapy. So this is after BRAF MEK inhibitor therapy. So in summary, BRAF and NRAS sequencing are a sensitive method to diagnose dedifferentiated melanoma when the immunohistochemistry is negative. They can expand the diagnosable spectrum of melanoma and also identify potential treatment targets. So next subject within melanoma is melanoma with spitzoid features. And this is a recently described entity which looks like a Spitz melanoma histologically, but does not have Spitz drivers and actually has BRAF or NRAS drivers. And the importance of this entity is that they behave much more aggressively than a Spitz melanoma, which has actual Spitz drivers. So these can potentially be identified by BRAF or NRAS sequencing. So to give you a little bit of context, this is the 2018 WHO melanoma classification, and it classifies melanoma according to initiating driver. So here are the melanoma categories across the top. So low chronic sun damage melanoma, this is the old superficial spreading melanoma. High chronic sun damage melanoma, This is lentigo-maligna melanoma. Then desmoplastic melanoma, Spitz melanoma, acromelanoma, mucosal melanoma, melanoma arising from a congenital nevus, and melanoma arising in blue nevus and uveal melanoma. And as you can see, the Spitz melanomas have a Spitz nevus driver, so HRAS or a kinase fusion, and this would be, for example, an ALK kinase fusion or an NTRK kinase fusion or a ROS1 kinase fusion. In contrast, the conventional melanomas have BRAF and NRAS sequencing. And then, just to give you a bit more detail on this table, the column on the left shows stages in evolution of melanoma. So early stage nevus, if there is a nevus in that particular category of melanoma, then an intermediate tumour that we're now terming melanocytoma, and then finally melanoma. And we'll come to that in the second lecture in much more detail. So these two figures show recurrence-free survival for Spitz melanoma in red, Spitz melanoma in green, atypical Spitz tumour in red, and melanoma with spitzoid features in blue. And if you first of all look at the right panel, the Spitz melanomas, when accurately classified using genomic information, actually have a very good prognosis, a very indolent tumour, quite similar to the atypical Spitz tumour, whereas the melanoma with spitzoid features in blue has a significantly worse recurrence-free survival. However, these are not very readily diagnosable just by H&E. So this is the situation before using genomic data. So here you see the atypical Spitz tumour in red, and this actually has some recurrence, and that's because in this category, this histologic category, there were mixed up some conventional melanomas with BRAF or NRAS drivers. And again, the green line here, the Spitz melanoma, also seems to have a behaviour similar to spitzoid melanoma, and that's because in the Spitz melanoma category, they were mixed up conventional melanomas with BRAF or NRAS drivers. So to get from here to here, 3 tumours were removed from the atypical Spitz tumour category and put in the melanoma with spitzoid features category, and 9 tumours were removed from the Spitz melanoma category and put in the melanoma with spitzoid features category. So in terms of practical applications, while BRAF or NRAS mutations are observed in benign nevi, when considering the specific differential diagnosis of atypical Spitz neoplasm versus melanoma, the presence of a BRAF or NRAS point mutation favours a diagnosis of melanoma. So here's an example of that. This is a tumour from the finger of a 25-year-old. It's quite a small tumour, but it subsequently metastasized and killed the patient. And this was initially called an atypical Spitz tumour prior to the genomic data being available. You can see it's quite a small wedge-shaped tumour. It has a diffuse proliferation of melanocytes which are quite epithelioid. They do have a little bit bigger nucleoli than you regularly get in an atypical Spitz tumour, but this tumour turned out to have BRAF mutation and a TERT promoter mutation and a bunch of other melanoma progression markers, so it would be more accurately classified as a melanoma with spitzoid features. And here's another example. This tumour was initially diagnosed as an atypical Spitz tumour. but metastasized, bulky metastases to the parotid. It's a fairly small tumour, again somewhat wedge-shaped, epithelioid melanocytes on high power, mitotically active. And this tumour also had, in this case, an NRAS mutation plus TERT promoter mutation, and would be more accurately classified as a melanoma with spitzoid features. So this is a very interesting study in which 20 experts were asked to categorize H&E virtual slides from cases with spitzoid morphology, histologic morphology, and they were blinded as to the clinical behavior and they were blinded as to the molecular information. So this table that I put together shows 3 of those cases where the tumours metastasized, so that we know without a doubt that they're malignant. And I've also added in the molecular information that the 20 experts were blinded to. And I guess the most important numbers in this table are over on the left here. So pre-NGS, 70% of the experts for this case, which was the first one that I showed you above, diagnosed atypical Spitz tumour. When they were informed of the NGS data, this number dropped to 35. None of the experts diagnosed conventional melanoma pre-NGS. After that rose to 60%. Of course, with the BRAF driver and these other pathogenic mutations, that should go up to 100% if you agree with WHO 2018 classification. Pre-NGS, 30% thought Spitz melanoma, and that dropped to 5% post-NGS. So this was the second case that I showed you with the bulky metastases to parotid. This 10% pre-NGS data thought atypical Spitz tumour. That dropped to 0 once the experts had the molecular information. Pre-NGS, 55% thought conventional melanoma. That went up to 90%, knowing that it was an NRAS lineage tumour. And again, the Spitz melanoma diagnosis dropped from 35 to 10%. And here's another fatal melanoma. No one was willing to call this atypical Spitz tumour, but the numbers went up from 60% conventional melanoma to 90%, knowing that it's a BRAF lineage tumour. So you can see, I think, that in these very, very hard to classify melanocytic tumours, molecular data does have a role in helping us make a more accurate diagnosis. There are some other features of NGS which help predict aggressive behavior. TERT promoter mutation in this same series was able to predict recurrence in the group of 101 cases, and also deletions in CDKN2A approach statistical significance. So moving on to another very challenging area of melanocytic pathology, and that's desmoplastic melanoma. So here are some clinical examples of really quite advanced desmoplastic melanomas. And you can see these are clinically very challenging because they're not pigmented, and they tend to, at late stages, develop a large infiltrative sclerotic plaque-like lesion. But early on, they can be very subtle clinically and also histologically. And here's an example. So A and B represent the first biopsy, C and D represent the second biopsy, and E represents the subsequent excision. But so that The A biopsy is a proliferation of extraordinarily bland spindle cells in a pinkish stroma, and this was missed. This was called neurofibroma. And then a little bit later, this is a bit easier to diagnose. I mean, you still have these extraordinarily bland spindle cells, but now you have a visible junctional component, and you also have visible lymphoid aggregates. So a little bit easier to diagnose at this stage, but still quite challenging. And then finally, when this tumor was finally diagnosed and excised some years later, it's much easier to diagnose because at this point we've got a clinically large expansile tumor with many lymphoid aggregates. But it would be highly desirable if it could be diagnosed at this early stage in evolution when it's still amenable to surgery. So there have been some attempts to use NGS to diagnose desmoplastic melanoma. So in this study, desmoplastic melanomas were sequenced and compared to desmoplastic nevus and desmoplastic spitz nevus, but not neurofibroma. And these are some of the closest histologic mimics of early desmoplastic melanoma. And the findings were quite useful in that truncating mutations in NF1 were present in the desmoplastic melanoma in 38% of them, but not in the desmoplastic spitz nevus or the desmoplastic nevus. Missense mutations in NF1, in contrast, could be seen in the histologic mimics. And then there are other melanoma progression mutations, for example, TP53, CDKN2A, ARID2, that were present in the desmoplastic melanomas, but not in the desmoplastic spitz nevus and the desmoplastic melanoma. And then the desmoplastic melanomas had a higher tumor mutational burden than the desmoplastic spitz nevus or the desmoplastic nevus. So you could ask, well, what about neurofibromas? Well, a separate study showed, quite surprising to me, that NF1 mutations are very rare in sporadic neurofibromas where KIR2DL5 mutations are recurrent. So potentially these findings could help to distinguish desmoplastic melanoma from neurofibroma as well. So here's an example of a desmoplastic melanoma that we know is exhibiting malignant behavior because it resulted in distant metastasis, a pretty subtle tumor with a fairly bland conventional melanocytic component, and then a more infiltrated but very bland spindle cell component, and infiltrated periphery with fat necrosis. This tumor turned out to have a NRAS Q61K driving mutation, as well as some other mutations that helped diagnose it as melanoma. This study used a similar approach to the previous study with melanoma with spitzoid features and asked 20 experts to look at digital slides without the benefit of the follow-up information or the molecular. And you can see for this case, only 45% were able to make a diagnosis of desmoplastic melanoma. The other diagnoses were all benign or intermediate. Whereas after being exposed to the molecular information, 75% were able to make a diagnosis of desmoplastic melanoma. And we know this case metastasized, so we know this isn't actually a melanoma rather than a histologic mimic. So it would seem in this case that molecular helped the experts make a more accurate diagnosis. And there are two more cases from the study where that's the case. This was a desmoplastic melanoma with an NF1 missense mutation, not a truncating mutation, but other markers of melanoma progression, mutation in P10 and CDKN2A, truncating mutation. 70% prior to having the molecular were able to make a diagnosis of melanoma, up to 90% of desmoplastic melanoma, up to 95% after knowing the molecular information. And here's an example of the third example of a metastasizing melanoma. This one did have a truncating mutation in NF1, but the experts were not foolable even without the molecular information on this one. So this is an example of another case from that study showing how the data might be applied. So this is a tumour with an NF1 truncating mutation, but several other pathogenic variants, favoured by the 20 experts to be benign before NGS and desmoplastic melanoma after NGS. So this is an extraordinarily bland tumour histologically. You can see it's rather paucicellular proliferation of spindle cells in collagenous stroma. So what is the diagnosis on this? So the 20 experts favour desmoplastic melanoma after being exposed to the molecular information, but is that truly the diagnosis? We don't really know without follow-up information. And here's another example, a tumour that was favoured by the 20 experts to be benign before NGS, but with the aid of NGS, a diagnosis of desmoplastic melanoma was established. And this case had an NRAS mutation, a TERT promoter mutation, an FGFR4 truncation. Again, rather bland tumour on the H&E, although there are some dermal mitoses and aggregates of these elongated spindle cells. So moving away from melanoma and onto another very challenging area in dermatopathology, and that's digital papillary adenocarcinoma. And this tumour has been made much easier in recent years by the discovery that most or maybe all tumours are driven by HPV42. So it's a tumour of digits, it can metastasize, it's quite easily missed, it's hard to distinguish from acral hydranoma. Some benign appearing tumours can metastasize. So here's the study results. 10 of 10 digital papillary adenocarcinomas had HPV42 by in situ hybridization, but none of the histologic mimics, and those were acral hydranomas and 22 other sweat gland neoplasms. And this is not this is not a difficult thing to diagnose now, because HPV42 features on the low risk HPV panel by in situ hybridization that's widely available. So here's an example of a digital papillary adenocarcinoma diagnosed with the help of HPV42 in situ hybridization. So you can see we're on a digit. This is acral skin. It's quite a small tumour. It has cystic areas. It has papillary projections. It has cribriform areas. Here, zooming in at the papillary projections, there are more solid areas which still have cribriform areas, and this is the HPV42 in situ hybridization, which enables accurate diagnosis. Well, so as a consequence of knowing this, we can expand the spectrum of papillary adenocarcinoma to some tumours at other sites apart from digits, and so far similar tumours have been identified on the scrotum and the vulva, and this is an example of a scrotal papillary adenocarcinoma, very histologically similar, partially cystic, partially papillary, cribriform ductal areas, and very strong HPV42. One of the close histologic mimics is hydradenoma, and this can occur on acral sites, on fingers and toes. And here's an example of a acral hydradenoma, and you can see this is quite similar in that it also is cystic. There are also papillary projections. There are also ducts. It's not mitotically active in general. It doesn't have a myoepithelium, but more importantly, it does not have HPV42. It does have, many of the cases, its own driver, and this is a fusion in the MAML2 gene. And this we can detect with fish currently. 90 to 100% of hidradenomas have a MAML2 fusion by fish break apart, and so with the aid of the MAML2 fish plus the HPV42, we can distinguish hidradenomas very accurately now from digital papillary adenocarcinoma. So next similar entity, papillary eccrine adenoma, also called tubular apocrine adenoma, and this, it's been recently discovered, has a BRAF V600E driver, and of course you could sequence it, but we can also use the BRAF V600E immunostain, which is positive in the tumour and negative in the surrounding stroma. So next entity that I wanted to look at is porocarcinoma. Porocarcinoma is an aggressive adnexal tumour. 10-year overall survival is as low as 55%. Lymph node involvement is quite common, 19 to 57%. I'm not going to labor the histology too much, but it has intercellular bridges, like squamous cell carcinoma, but it also has ducts with a refractile cuticle, which of course you don't get in squamous cell carcinoma. Nevertheless, it can be a challenge to distinguish it from squamous cell carcinoma. But porocarcinomas have fusions, YAP1 NUT-M1 and YAP1 MAML2 fusions. And we can use these to distinguish from SCC. So the immunohistochemistry for NUT-M1 is positive in 50 to 58% of tumours. And we can also use YAP1 immunohistochemistry, and that's because in the fusions, the YAP is fused with either NUT-M1 or MAML2, and the C terminus of YAP1 is lost in the fusions. So the YAP1 C terminus immunohistochemistry actually looks for loss. One caution about using this: it's lost in a fraction of SCCs as well. So here's an example of how the immunostain could be used to distinguish porocarcinoma from squamous cell carcinoma. So here's you can see on H&E in these images, at least the porocarcinoma and the squamous cell carcinoma look really quite similar. But in the porocarcinoma, we have NUT1 overexpression and YAP1 loss. So this is probably a NUT1 YAP1 fusion. In contrast, in the squamous cell carcinoma, where these fusions don't really operate at all, NUT-M1 is negative, and the YAP1 C terminus is retained. So this would work fine for the porocarcinoma, which has got a YAP1 NUT fusion, but in the porocarcinomas with a MAML2 fusion, you'd have to use the MAML2 fish. Next entity, nodular fasciitis. So here's an example of a cutaneous nodular fasciitis. You can see it's a relatively circumscribed nodular tumour, and zooming in, it's a spindle cell neoplasm. There's prominent red cell extravasation. There are myxoid areas. It can be mitotically active, and the danger with nodular fasciitis is overdiagnosing it as a sarcoma. But diagnosis of nodular fasciitis has been made much easier in recent years by the discovery that it's driven by USP6 fusions in a large proportion of the cases. So this study from 2011 showed 44 of 48 cases of nodular fasciitis had USP6 fusions. So we can diagnose this with a USP6 fish break apart probe. So this confirms that it's a neoplasm rather than a reactive process. At the time of the publication of this paper in 2011, nodular fasciitis was thought to be a self-limited neoplasm. You can see they use the words transient neoplasia because many of these tumours involuted by themselves. But now that the USP6 fusion is more widely available and can be used to help recognise the entity, there's a range of more atypical nodular fasciitis that's recognised, and even metastases after multiple recurrences. So here's an example of a case of nodular fasciitis that did metastasize. So panels A and B represent the initial diagnosis of nodular fasciitis. Here you can see the red cell extravasation again, the myxoid areas. But this recurred 4 times. It's the first recurrence, second, third, fourth. And by the time of the 4th recurrence, 10 years later, this tumour had also metastasized. All of these tumours had the USP6 fusion. So once you have a method of more accurately diagnosing a neoplastic entity, you can expand the spectrum based on that test and more accurately know the full spectrum of possible clinical behaviour. This case may be a bit different from a regular nodular fasciitis in that there was fusion, but there was also amplification of the USP6 fusion, which is not a common occurrence. So the nodular fasciitis spectrum can be expanded to include more cellular, more cytologically atypical tumours as well. And this is an example of that. Here's a more cellular tumour. It still has this sort of collagenized stroma that we sometimes see in nodular fasciitis, but it's definitely more cellular, but also has a USP6 fusion, so can reasonably be included in the nodular fasciitis spectrum. So, complete change of gear. I'm going to talk about some lymphomas where there's been some striking progress recently. And this is aggressive epidermotropic CD8 positive T-cell lymphoma, and it's recently been recognized that a high proportion of these tumors have JAK2 fusions. So this is an aggressive cutaneous lymphoma, characteristically presents with ulcerations. It can disseminate widely and patients have very high mortality. But recent data shows that in 8 of 9 cases there was a JAK2 fusion, which was not present in gamma delta T-cell lymphomas or in 19 cytotoxic T-cell lymphoma not otherwise specified. And we can diagnose this with a JAK2 FISH, break apart FISH. This opens up the possibility for targeted therapy with JAK2 inhibitors, although there's no clinical trials of this as yet. And it also opens up the possibility to expand the spectrum of disease to include cases with an indolent prodrome, so that we can diagnose the disease earlier. And here is an example of a patient with aggressive epidermotropic CD8 positive T-cell lymphoma who did indeed have an indolent prodrome. And there are cases that are misdiagnosed as a dermatitis early on because of this indolent prodrome. One note of caution, there does seem to be some JAK2 fusion-driven mycosis fungoides. So unfortunately the picture may be going to get a bit more complicated when all the data's in. Next entity that I wanted to talk about is subcutaneous panniculitis like T-cell lymphoma. This is an example of a patient with subcutaneous panniculitis like T-cell lymphoma. It's a very indolent lymphoma. It's often associated with lipoatrophy, and you can see this patient's left leg is affected by severe lipoatrophy, but in this indolent lymphoma, it's localized primarily in this leg. The histologic features, which I'm not going to labor too much, are an infiltrate of lymphocytes which love to line up around adipocytes in the subcutaneous fat. So a bit more about subcutaneous panniculitis like T-cell lymphoma. It's an indolent lymphoma. A severe complication is hemophagocytic lymphohistiocytosis. You can see lipoatrophy in 30%. Its close histologic mimic is lupus profundus, in which you can also see lymphocytes lining up around individual adipocytes, and this is made more challenging by the fact that lupus or other autoimmune disease is present in 36% of bona fide subcutaneous panniculitis like T-cell lymphoma, and that's because autoimmune diseases are thought to be risk factors for development of subcutaneous panniculitis like T-cell lymphoma, and antibodies can frequently be detected in 62% of patients, especially ANAs, even in patients without a diagnosis of systemic lupus. So the diagnosis of this entity on a skin biopsy has been made quite a lot easier, I think, by the discovery that mutations in HAV-CR2 underlie many cases of subcutaneous panniculitis like T-cell lymphoma. But this is germline mutations, and they're biallelic rather than in the tumour itself. So some of these studies show that 60% of familial cases and 85% of sporadic cases in Asia, and this is China and Japan, have germline biallelic loss of function mutation in HAV-CR2, resulting in immune overactivation. This is lower in a European study, and that's probably because these loss of function mutations are just lower outside of Asia in the general population. So the idea is that the HAV-CR2 is a transmembrane molecule that normally downregulates immune activation, and when there's germline biallelic loss, it fails to downregulate a clonal T-cell proliferation with limited growth potential. So although this mutation may not be quite as useful in the US as it might be in Asia, if you do have the HAV-CR2 mutation, it's predictive of evolution to severe hemophagocytic lymphohistiocytosis, and also knowing that this is a lymphoproliferative process rather than reactive, we can look for other pathogenic lymphoma mutations, and subcutaneous panniculitis like T-cell lymphoma patients have a mean of 6 other pathogenic mutations. So even if you do sequencing, you don't pick up HAV-CR2 germline, if there are other pathogenic mutations, it can help you get to a diagnosis of subcutaneous panniculitis like T-cell lymphoma. So one other thing that may be ultimately useful is an immunostain for HAV-CR2, and here's a wild type patient with 2 functioning alleles, and the HAV-CR2 is localized normally on the cell surface of some cells in this biopsy, and that's lost in the homozygous loss of function mutation. So I just wanted to touch briefly on histiocytoses, and that's because there's been a lot of exciting progress in understanding the molecular drivers underlying histiocytic neoplasia. I can't possibly go into all of this in much detail, but this pie chart shows Langerhans histiocytosis, and you can see that about 60% of it has a BRAF V600E driver. In non-Langerhans histiocytoses, it's about 50% have a BRAF V600E driver. So the non-Langerhans is broken down here, and this is ECD is Erdheim-Chester, juvenile xanthogranuloma, Rosai-Dorfman, indeterminate cell histiocytosis, interdigitating dendritic cell sarcoma, follicular dendritic cell sarcoma, and histiocytic sarcoma. But I just wanted to focus for a couple of slides on Erdheim-Chester disease and point out that 50% of Erdheim-Chester has got a BRAF V600E driver. And Erdheim-Chester has until quite recently been a very poorly understood process. It's not even been clear if it's a neoplasm or a reactive process. I just want to show you some of the manifestations of Erdheim-Chester disease. This is encasing of the thoracic aorta by histiocytic infiltrate. There's CNS deposition. This is hypothalamus and pituitary. This is a mass in the right atrium, I think. This is one of the characteristic clinical findings, which is deposition in the long bones leading to sclerosis of the femur and the tibia. This is one of the characteristic clinical findings. It's deposition, retroperitoneal deposition around the kidneys on these two images. As far as the dermatological manifestations, patients can have these xanthelasma-like lesions, cutaneous lesions. And this is a biopsy of one of the xanthelasma-like cutaneous lesions. And I think you can see that it's pretty nondescript. Here's a multinucleated giant cell, a bit like a Teuton type giant cell, and then there's some sort of nondescript histiocytes and foam cells. But here's the BRAF V600E immunostain showing that these Teuton type giant cells plus many other histiocytes in this biopsy actually have a BRAF V600E mutation. The importance of this is that targeted therapy, including BRAF targeted therapy, actually works very well in some of these histiocytic neoplasms and is now first-line therapy for Erdheim-Chester with a BRAF V600E mutation. So that's it for my individual diseases, but I just wanted to give you a feel for how much this field has progressed in the last few years. In red, I've highlighted immunostains or tests that were available 2008. 2008 has no significance except it's the year that I returned to academics. So in red are the tests that were available pre-2008, and in black are the ones which have become available since then. So this slide shows immunostains that identify a fusion driver gene that's important in dermatopathology. See ALK1, we have soft tissue tumours, we have epithelioid fibrous histiocytomas, we have systemic lymphomas, all diagnosable with ALK1. PAN-TREC is useful for soft tissue tumours and Spitz tumours, ROS1 for Spitz tumours, NUT-M1 for porocarcinoma. FOSB is useful for angiollymphoid hyperplasia with eosinophils. CAMPTA is useful for epithelioid hemangioendothelioma. SS18-SSX is useful for synovial sarcoma. PLAG1 is useful for mixed tumour and myoepithelioma. YAP1, as we've seen, is useful for porocarcinoma, and DUX4 for chick-dux fusion sarcoma. So this figure shows immunostains that identify a key tumour suppressor gene in dermatopathology. These were available pre-2008. MSH2 and MSH6 for Muir-Torre, P16 for melanoma. But now INI1, and we can use that for epithelioid sarcoma, epithelioid malignant peripheral nerve sheath tumour, epithelioid schwannoma. We can use BAP1 loss for BAPoma and also malignant blue nevus. We can use PARCAR1A for superficial angiomyxoma, amongst other tumours. We can use P10 for diagnosing Cowden syndrome. We can use RB1 loss for spindle cell lipomas, pleomorphic lipomas, and cellular angiofibromas. This is a list of immunoassays that identify key amplified driver gene in dermatopathology, and I've listed HER2 that we can use for metastatic breast cancer, and c-MYC that we can use for post-irradiation angiosarcoma and also lymphedema-associated angiosarcoma. Here are immunostains that can be used to identify a point mutation in a key driver. BRAF V600E, we've seen the widespread utility of that. And there's also an immunostain that identifies NRAS Q61R as well as HRAS Q61R. Immunostains that identify a key viral pathogen driver in dermatopathology, HHV8, spirochete, and also Merkel cell polyoma virus. Break apart fish probes that identify a key fusion driver in dermatopathology. EWSR1 we can use for clear cell sarcoma, myoepithelioma, angiomatoid fibrocystocytoma. PDGFB we can use for dermatofibrosarcoma protuberans. JAK2, as we've seen, we can use for aggressive epidermotropic T-cell lymphoma. MAML2 we can use for hydradenomas and also porocarcinoma. IRF8 we can use for lymphomatoid papulosis and for primary cutaneous CD30 positive large cell lymphoma. FOSB we can use for angilymphoid hyperplasia with eosinophils and also pseudomyogenic hemangioendothelioma. And USP6, as we've seen, we can use for nodular fasciitis. And finally, a list of in situ hybridization that identify key molecular drivers in dermatopathology. HPV42 we've looked at, Merkel cell polyoma virus, EBV, very, very useful test, and PDGF beta for dermatofibrosarcoma protuberans again. And markers that guide targeted therapy in dermatopathology. CD30 can be used for guiding anti-CD30 therapy. HER2 for anti-HER2 antibody conjugates. CD123, there's a new antibody that targets CD123 expression in blastic plasmacytoid dendritic cell neoplasm. And then these Spitz tumor fusion drivers are also useful for soft tissue tumors that have fusion drivers, and there are good drugs to target these available now. So, final slide. Identification of key molecular drivers for a disease can lead to more accurate diagnosis, possibility to redefine the entity on molecular grounds, and also the possibility of targeted therapy. Thank you very much. And any questions?